So I took the chair's prerogative to switch two of the talks and to ask Fiona McTavish to come on next, simply because she and Lisa have obviously worked closely together. Lisa gave a nice introduction to the HS. You know, it's interesting to wonder how people get involved in this kind of work, and I would mention that Lisa Marsh had her training within the substance abuse research field, so she was very conversant with that. And if I'm not telling tales out of school, she has a husband who's an ace computer programmer, and that would have been, I'm sure, an influence on getting into the technology area. But with Fiona McTavish, there's a different pathway, and I've asked her to actually tell us how she got interested in substance abuse, because Fiona comes from Madison, Wisconsin, the University of Wisconsin, where she's in the Department of the College of Engineering, and talk about a nice example of transdisciplinary collaboration, to have somebody from a College of Engineering coming to our program to talk about substance abuse treatment. So without any further ado, let me introduce Fiona McTavish to you.
Thank you very much. Before I tell you kind of how engineering got involved in this, I want to say that this group holding this conference is one of the most flexible and gracious group that I've worked with. And I always thought we had a really good team, but I think you've raised the bar. So thank you to all of you for putting this on first and foremost. So engineering and this stuff, how does this work? Dave Gustafson, who I work with, is the PI, and we call him a fake engineer. He's an industrial engineer. And what they were really known for is bringing together, where they first kind of got their name in the healthcare field, is when people went into operating rooms. There used to be a lot more deaths than there are now, because the operating rooms weren't standardized. And so one anesthesiologist would flip a lever up, and it would mean that it was doing what it was supposed to. And in the next one they'd go into, it was flipping it down, and it did the opposite things. And so what industrial engineers did is came in and really improved the system. And so that's kind of how industrial engineering fits in with healthcare and then into addiction and all sorts of things. And Dave is just an incredible person of bringing teams together, and I feel very fortunate that I work with him, not for him. I mean, I know I work for him, but I really feel like I work with him. So let me go into a little bit about what we're doing. And the best way to do that is really to show a video. And so I'm going to have a little bit of assistance here so we can get this video up and show you this smartphone intervention that we gave to people in the substance abuse field treatment.
In the very back seat of the number 12 bus, only Jeremy's eyes were moving as he scanned the shadows outside, his forehead pressed up against the glass. He had missed his stop. It was 1:30 in the morning, and when the bus had approached his street, he had imagined lifting his arm up to pull the cord. He had imagined himself walking up the stairs to his crappy little apartment. He had imagined himself flop into his grubby, sunken couch and pull his tiny TV close enough to watch. But he hadn't pulled the cord. He was motionless, with a tiny spark of excitement and a tiny spark of nausea circling like flies in his stomach. The park 10 minutes ahead, on the number 12 line, is where he used to score. He could feel it getting closer, though he couldn't see it. He had no intention of getting off the bus at the park. He just wanted to drift by and catch a glimpse. He was shaken out of his trance when his cell phone went off. He recognized the ringtone right away. HS. Jeremy always responded when the HS alert went off. He didn't want to miss out on an easy $10 which his counselor would give him for each week he didn't miss a response. HS was an app on his phone that his counselor, Brenda, had set up for him during his last week of inpatient treatment. Brenda had tailored HS to Jeremy's specific needs by asking him a series of questions about where and when he used to use and what his triggers were. HS knew that Jeremy was a night owl, and oftentimes the application would check in with him at night to see how he was doing, and sometimes suggest he listen to some guided relaxation, or maybe suggest a meeting for him to attend the next day, if he hadn't been to one in a while. Jeremy had already received a check-in from HS at 11, but now his phone was vibrating because the system had detected that he was near one of his high-risk locations. After Jeremy answered a few brief questions about how he was feeling, HS presented Jeremy with some suggestions based on his answers. The system had determined that it was important that Jeremy have a video call with an on-call counselor right away. Jeremy didn't think that was necessary, but when he tapped on the ignore button, HS played a video of himself talking about his life prior to treatment. Jeremy sat back in his seat and thought about it for a minute. I cannot afford to be that guy again, he thought. He reconsidered and tapped on connect. Jeremy looked around. The bus had passed the park, and he was heading back west. I'm the only one in here, he thought. This shouldn't be so bad. He sat up a little straighter and positioned the phone in front of him. Within a minute, he was talking face-to-face with his counselor, Brenda.
But that gives you a little bit of an idea of what the system is and what we're doing. Well, I can give you a link with the video, and actually, so feel free to ask me afterwards, and I can happy to get that to you so you can see the whole thing a little bit easier. So we're doing a clinical trial of this system, and we'll ignore that. And basically, this is the smartphone that people had. You can see it had other stuff on there that we touched on briefly, had the meeting locator. And what we did in this study is when people were leaving a treatment center, we used two treatment centers, one in Peoria, Illinois, and one in Boston. And what happened is 2 weeks before they were about to leave treatment center, that was the ideal 2 weeks before, is we would ask them we would approach them and ask them if they wanted to be in the clinical trial. We'd explain it, get consent, and then they would be randomized either into the HS group, and HS stands for the Addiction CHESS, and CHESS is the Comprehensive Health Enhancement Support System. You'll never have to remember that. I hardly do anymore. And what it did is they were randomized into one of those two groups. If they were in the control group, they got treatment as usual, which in both of these clinics is that basically when they left, it's, you know, we really suggest you go to AA or other type meetings. There is some follow-up programs you can do here, but nothing was really pushed at them. They either came or they didn't. There wasn't much follow-up, which is pretty typical of exiting treatment centers at this point, or at least it was then. Or they were in the HS group where they got the phone and they had access to it for 8 months. We would provide them the phone and the service plan. It was an unlimited service plan that they could use. And then we did surveys at 4, 8, and 12 months along with the pre-test. So we approached 380 people. If you exclude those who were ineligible, about 95% said, yes, I want to be involved in the study. I mean, it's kind of a easy decision for most people, but those who just did not want a phone. They felt that they did not want to have something that could either have GPS or tracking or anything like that. Even though they could turn that off, they were, you know, I don't want that, period. So we weren't going to convince them. It's not for everybody, but it's certainly the majority of people were interested. And then the randomization, you can see the two groups. There's 170 people in the HS system. I gave some demographics here, and I thought I had switched these, but I guess I'm on the old one, so we'll go back to this. Basically, people were, let me go back one here, were about 61% were male, mean age of 38, majority were white. 20% had never completed high school. And all of this stuff is in your package, so don't worry about trying to keep up with this. I'm going to try to go through it quickly, and I have changed things, but we'll see which one I'm on here. This is why they got there. 94% said they came on their own initiative, and when I talked to the counselors, they just kind of laughed and said, well, they may have said that, but reality is different. They could check multiple things here, and that's why it adds up to more than 100%. And the big issue on this slide is the majority, only about 30% were either going to live with family or other relatives that they knew. The majority didn't really know where they were going to live, or they were going to live at halfway houses after their treatment. So a pretty transient group who've probably run through their family and friends at this point and don't get a lot of support there for a good part of them. 63% almost had other drug issues, and 47% had co-occurring mental illnesses like bipolar, depression, that sort of thing. So the clientele that you guys are all very, very familiar with and know, it was your typical clientele in these two places. And obviously job loss and relationship issues. Our primary outcomes of this study was really to see if HS compared to the control group would reduce number of risky drinking days, would increase complete abstinence, and decrease negative consequences as a result of drinking over that 12-month period. So again, for those who got chest, they had it for 8 months, and then there was a 4-month post-test after the intervention was taken away. And what we found is really encouraging. Basically, as you can see here, the HS group is in the red, and that's the number of risky drinking days at the various time points where we reached them. And we had a great percentage of people who we were able to reach and follow up both in the control and experimental group, where it was close to 90% of the people who were on the study we actually did follow up with and talk to. And then at 12 months, I was really mad because we were going to try to keep it at 80%. It was 79 point something, and I couldn't get there, and there was nobody else to reach. We were trying nonstop. But very good turnout of people we were able to really keep track of. So there was a significant difference there in the reduction in risky drinking days of these folks. And that was significant at the 0.003 level. And in that one at the 12 month, it was actually a 57% reduction in drinking days of the participants. The other thing we were looking at is complete abstinence. And I need to say that again, we showed positive results here at the 4, 8, and 12 month and significant results. But remember, when we're asking this, what we're asking is at the 4-month mark, and I actually did a lot of the calling just to make sure I really knew what was going on. We asked, in the last 30 days, have you drank? So at the end of 12 months, it wasn't that 79% of the HS group had not drank at all in that last year, but in that last 30 days. So I just want to make sure that we're portraying the truth here and not misleading you on the data there. Again, we are very pleased with these results of this clinical trial, and we're in the midst of writing a paper that hopefully will get out in the next month to a journal and get a publication about these results. One of the things is we did not see any difference in negative consequences between the control and experimental group, in part because our numbers at that point were so low. And we had a ceiling effect. Everybody was kind of saying they were up at the top. So we did not find negative consequence reduction that we had hoped to see, but we did find the other two outcomes that I mentioned. One of the things that happens is a lot of people download health applications. I don't know about you, but I have one on my phone. I'm sure other people have downloaded stuff. And according to Joseph Kevdar, excuse me if I pronounce his name incorrectly, but he basically says what happens is people download these things, but then they never use them. And it's incredible, the drop-off rate, quite frankly, of what happens. And so I stole a slide from Pinch Media, and this is what happens with free health applications. Just one day after downloading, only just over 20% are still using it, one day afterwards. At 3 months out, this is what they have said, at 3 months out, you're lucky if you have 1% who are still using it. So the use, it's a shiny new toy that they get, they download it and then never use it. And I know, I know there are many applications I've done that with. I download it, look at it, and said, meh, I either can't figure it out, so I don't want to use it, and it's just too intensive, too time intensive for me, or it's just not doing what I thought it would do. So, so we were really interested on our cell phone, or the smartphone. We track everything that they're doing on this. And so we can't track text messages outside of our system, but as far as their use of the system, and particularly of HS, so not just using the phone, but how much are they using the application we gave them. And what we find is in day one, 70%, over 70% are using it. At the end of 8 months, 240 days out, it's still over, just under 30%, somewhere between 25 and 30%. So there's extended use going on, which we're very pleased about. And if you break this down into weeks, in the first week, you have over 90% of the people using it. And then by the end of 8 months, 32 weeks, you have just about 60% using it. And I've worked on interventions with Dave and our team for, I'm afraid to say, about 20 years now. And we started with DOS programming, where we gave laptops, computers for women with breast cancer, and took it out to their home and helped them to use it, figure out how to use it. We'd go and train them. And it really dropped off tremendously. You'd get the beginning people using it, and then you had a drop-off rate, and it stayed at about 20% who are using it. When we went to mobile devices, we've done one with teens with asthma, trying to help them control their asthma better. And the addiction chest was actually much better used than even the asthma. So we're really pleased with what's happening, is that people continue to use it over time. And even if they do lapse, they're getting back on track quicker, and so that's a really positive outcome too. So we're very pleased with kind of how that's moving ahead. Obviously, there's limitations to this study, like any study. When we first did it, and I should say this was funded, excuse me for kind of jumping quickly here, but it was funded by NIAAA. And when we first did this grant, we were going to do urine analysis and have more hard markers on stuff. But this is all self-report, and that was simply two reasons: budget, and secondly, just the difficulty, given the transient nature of this population, of would we really be able to get them. And so it was a tough decision that we had to make, but it is self-report, and there are obviously limitations with that. Secondly is obviously to provide phones. Phones you can get relatively cheaply now. The services plans aren't cheap, and oddly enough at the university you would think that we'd be able to get whatever the plan is out there in the real world, and our plans actually cost more. I don't get it. We have I've fought this one forever as we're doing furloughs and things like that, and I said, so you mean to tell me I'm going to pay more for this plan than if I went out as an individual? Yep. But even if we were paying as an individual, it's a fairly steep price for us to use our cell phones. I mean, most of us in this room probably have them and pay that bill every month, and you know what it costs. But if you can save people either from being in jail or you keep them out of treatment and they're doing better, then it doesn't take long before you've made up the cost of that plan, even up for a year. So it really is, it's costly, but not as costly as what it's costing us now. And the other thing is this study was done in only 2 clinics, as I mentioned, one in Peoria, Illinois, and one in Boston. And so, you know, the representation, how representative is that, is a bit of a question. But we're doing some other studies, and so I'm going to talk about some pilot studies, not clinical trials, to show kind of where we've grown and keep moving with this. So we've done one with the Massachusetts Drug Court, and I'm going to really skip through some of this this stuff because this is a bit older, the slides that I have up here. But same sort of, you know, 76% male, 36 years old in general, other mental health issues going on with them. And in this case, because there's no control group, we couldn't say, you know, the X group did better than Y group. What we could do is go ahead and look at how people use the system and then break it into high and low user groups. And so kind of a dose effect sort of thing here. And what we found is that the people who used CHESS more had more benefit as far as they had less positive drug screens. So 6.5% who used it more had positive drug screen tests, whereas 11.6% in the low use of the system. So use of the system is important, and engaging people and keeping them engaged is important. On average, people were using it every other day, but there was about a third of the people who were using it 75% out of the time. So 3 out of 4 days they were using the system. And the offenders and the drug court staff reported that the discussion board that they have on the system really became an extension of the group that they were in, and it really helped. It was there not just that 1 hour a week or 5 hours a week, however much they met, but it was there 24/7. Anytime they needed it, it was there. It helped create strong ties and improved engagement in the treatment itself. We've also done a VA pilot with Chris Wilkinson up in the New York area, where what he's done is provided HS to vets, and he gave it to 47 vets. And how it was determined who got to get the phone was they were trying to get kind of the harder core people that they were really having trouble with. And so they picked people who had been hospitalized and doing detox at least 3 times in the last 18 months. And so those were the people who were in this study. And what happened in there with them is they had an 84% reduction in the admission to detox in their center. So Chris is talking with us more about how to extend this out even further. But I want to, I think that that's a really important thing that Chris said, but I want to make it real too. I don't want to give just stats. I'm really an applied person. And what motivates me is seeing that people's lives are changed. So I'm going to share one exchange that went on in the discussion group with these, as Chris calls them, the platoon of brothers. He said, what's really nice about the VA is you already have this mentality, this platoon of brothers who are there to support each other. So bear with me as I just read to you some of the discussion that happened one night. And I'm going to call the main character who was posting Jeff, and then everybody else I'm not giving names to. But Jeff at 7:02 p.m. My father passed away this morning. Been a hard day. This man cried like a baby, and I don't care. Egotistical is gone, but I got more crying to do. I miss Dad already. He made me want to do good, so he was proud. But I hope he died proud of me, knowing I was trying to do good. 7:06 p.m., someone replies, you know he's died proud of you, man. You're on the right path, doing the right thing for the right reasons. It's all good, bro. Feelings will be hard to handle sometimes, but all you got to do is reach out and say a prayer. The Lord will provide. Above all, your sobriety is worth everything. Another one at 7:06. Sorry for your loss. Keep doing the right thing by working your recovery program. 7:26. My condolences go out to you and yours. Stay strong. He would have wanted you to. 7:29 p.m. Truly, your pain is the greatest pain there is. When love departs, always we want it back. I have felt it. 7:46 p.m. Continue to stay on your path of recovery. He would have wanted it that way. God bless you and yours. 8:22 p.m. I feel your pain, brother. I am sorry for your loss. My prayers to you and your family. Hold on, my brother, hold on. We are here for you. We love you. At 8:51, sorry for your loss. Be strong. At 9:13, Jeff wrote again, and he said, I'm struggling hard. 9:16, keep the faith. What hurts us makes us stronger. 9:17, Jeff wrote again, really struggling at this point. Now I'm back into wanting what I can't have. The sexy BI with the goods, old habits. Sex is my weakness. I hate it. That's not me. At 9:23, someone wrote, a reed furthest from the river grows the strongest. A wind-blown stalk avails the current. Man is appointed to die, and separation makes the heart grow stronger. Take comfort in your faith. Life and death are two sides of the same coin. Jeff wrote again at 9:25, thank you. I'm going on my own. Mental health is bad. 9:27, someone wrote, life for man on earth is a constant warfare. Will you fight or will you die? 9:38, Jeff, you cannot change the wind. You can only adjust the sails. Your wind is blowing hard. What you need to do is adjust yourself. Look within you. Have that power. Your sobriety is power. Use it. You're a fighter. You can do this. At 9:46, my deepest sympathy. I can't even begin to imagine how you must feel. Hang in there. Keep talking to these wonderful people. We are all here to help you through this very difficult time. This messages are exactly what happened on our message board. It was 2 hours and 44 minutes of veterans holding each other up as they struggled. Jeff did not relapse. And in part, he says that chess helped him in this time and helped save his life. I'm not sure that it helped save his life, but this is just an example of how giving people a smartphone like this can really make a difference in their lives and really help them as they struggle through different things at the time they need it, not at a clinic time. So this really does become a clinician extender sort of thing with people who are holding one another up. I don't know about you, but often people have told me, as I was going through different things, call me anytime you want. And I don't know how many of you have really called someone at 2 a.m. when they say it's okay to call. I can't bring myself to do that, even if I may be up and struggling with something. But through this, you can do it in a much more easy way, which is less interfering to people, and they can respond if they're there and available. So that's a bit of what we're doing. What next? Lisa mentioned the HS and TES, which the two systems we're combining for addiction and using much more of the work that Lisa has done to help people with working with CBT type programs. And SIVA is a Sanskrit word for selfless caring, so that's how we came up with that. We're doing stuff to move beyond just one disease. So much in the healthcare field, we look at diabetes or addiction or whatever it is, but in real life, we're usually dealing with multiple things, especially as you get older and have grayer hair. You're not dealing with just one issue, you're dealing with multiple issues. And we need to look at things more wholly and not separately. And so that's what we're trying to do there. But the main thing really, and Maxine and the entire group has really encouraged us and stretched us, is that dissemination is really what's important. So we know this works. We've seen some clinical trials where it's working. I've done a number of pilots. And now it would really be absolutely, I don't even know the strongest word I want to use. It would be awful, actually, to have this sit here in an ivory tower at the University of Wisconsin and not out to people so that they can actually use it and benefit from it. So we need your help in doing that. We do have a research consortium that we're doing so that different clinics can use it, and we're trying to make sure that the price to do that is as low as possible. We know the addiction field doesn't have money, and we're not in it for money. We're just trying to get it out there and help people, but we have to make sure we have enough so that we can keep it running appropriately. So there's that way, and hopefully what we'll do eventually is have it where anybody can get it, just download it as an app as well. So that's what we're working on. We're not quite there yet, so keep pushing us, and we'll get it to you and hopefully bridge that gap. So thank you very much.